Good evening, everyone, and welcome to our training, Lips No Touch Technique for Lips Beautification. And please welcome our expert for tonight, Dr. Javier Beut. Hello, Dr. Beut.
Hello, good evening.
Dr. Beut is a very famous plastic surgeon from Spain. And Dr. Beut is here among us tonight to exchange with you his various techniques. And do not hesitate ask him questions on our website, www.cible-channel.com. Dr. Beut, can you explain a little bit about to us what is the technique that you are going to use and why we call it no-touch technique?
Okay, it's a good question. We have published this on the PRS Reconstructive Journal. It's a technique based on a lot of backgrounds on reconstructive surgery on the lip, where we have done a lot of cleft lip and palate, and then from this kind of surgery, we have developed, this type of technique for the lips. So the base of this, of this technique called no touch is because we never, of course, I have to touch the lip, because if I don't touch the lip, we have no kind of result. But the most important thing, can you open a little bit your mouth? So it's to do everything from outside by cannula or by needle. I always recommend to do by cannula. Why? Because when you use cannula, you are going to place the product at the proper space. The product needs to be placed at the submucosal space, not intramuscular. Because if you place intramuscular, the shear forces and the vascularization of the muscle, helps to make this product disappear earlier than than in another place. This is the first concept of no touch. Then we have developed the following things. We have developed the profile. We have developed what we call the projection. And we have developed, the concept of augmentation. So we have three. So projection, profile is going to be what we call, this is called the wide roll. And the wide roll is the junction between the skin and the vermilion. Is what, from the embryology point of view, is what the Klein muscle were, when we were children, feeding, the breast of our mummies. So it was this Klein muscle, disappear, and then makes, this big, differentiation between the skin and the vermilion. Then, if you look carefully, we had what we call the red roll. The red roll is the junction, is invagination of the orbicularis into the mucosa. Is what we call this will be the dry mucosa and the wet mucosa. So, open please. So what you can see here, I'm dividing, the lip into, all these parts. So we have the lip is divided by the columns at the upper part in 3, and at the lower part in 2, because we have 2 parts from the because during the first 11 weeks of development, we have 3 parts that form the upper lip and 2 parts that form the lower lip. So don't try to do the lip in just one single shot, because then we have these bananas or whatever you want to call lips. You have to do the lips in 3 parts, so the 2 lateral parts and one medial, and from the lower part in two parts. So the patient had I think in June. Yeah. She had some kind of treatment on the lips, and if you look carefully to her, she has the upper lip is hanging a little bit over the lower lip. So in her case, we're going to do what we call an augmentation at the lower lip. So I'm going to work not between the white and the red, but I'm going to work inside the red roll. Then at the upper lip, because she has already very well defined upper lip, I'm going to work only at the profile, so at the wide roll. So for the upper lip, I'm going to use what I call, the fine lines from Filorga, and then at the lower lip, I'm going to use the lips from Filorga. The thing is, another very important thing, I want to mention this. One of the keys of success is the analysis. So what you need to do is a picture of the patient and a big smile. And now the patient cannot do the smile because I always add some local anesthesia, laterally, because I don't like, in Spain, we don't like, our patients, suffer. So what we do is we ask the patient to smile. Try to smile. I don't think you can. Okay. When the patient smiles, if the patient, when she smiles, we see what we call this the gingival line is negative or non-harmonic, that means that the patient can have augmentation. If the patient, when she smiles, the upper lip covers, the teeth, she can have augmentation, but she can have projection. So that's why I make these three important differentiation between differences from profile, from projection, and from volume or augmentation. So these three concepts need to be identified beforehand, before the patients, start. So let's to proceed. Can you give it the gloves? So I have added some local anesthesia. You see the whitening here. The whitening, because I like to use always some local anesthesia with epinephrine. I use this all along the face when I do any treatment. So, give me this. So, open a little bit. So, then I go down, to the skin. Give me some gauzes. Give me some gauzes. Then I remove this. If I found a hole, because it's, when someone becomes older. Okay, and then I go down, you see? You see where my cannula is now, right now? No, you cannot see it. You have to watch here. The cannula is now between the white and the red. So I don't want to do it here. I have to go, behind the red. You see? Slowly. Slowly.
Excuse me, doctor?
Yes, please.
Sorry to interrupt. There is a question from Dr. Leblanc from France. He asked, what is your plan for the injection? Your plan of
what
injection?
I'm saying is I'm just, and then look to that. You're going to see that the product is coming out. The product need to be out always from the lip, because it's just to give, support, close, to give support to the corner of the lip, to the commissure. It's very important, all right? So this is the first. So and then I don't know if you notice that the cleft of the lip has been enhanced, the cleft of the lip. This is what years ago, a lot of patients asked us to do, Angelina Jolie's lips, because she has a very natural cleft. So if you just stop, with your injections, just before the two parts, then you are creating, a very natural cleft. So I have just, done, the infiltration between the red, behind the red, so to obtain some types of augmentation. Now, I'm going to use, now for the upper lip, fine lines, always remove. And so I follow also, you see, from the same part, always under tension. You place the lip under tension, and then slowly, you see, if it doesn't go through, you are not on the proper plane. Slowly. And that's it. I'm already here. So the thing is, now I'm over the wide roll. So I have to look at my mark of the needle, just to obtain the direction I'm looking for. So I'm going to just to give a little bit of profile to the patient. I don't need a filler with a lot of projection. So if you see, I have just give a little bit of profile on the lip. So the lip has been projected a little bit. So now I have to turn. I have to go to the other side, or maybe I can do it from here. I want to check if you are able to. I don't know if the patient stands up, and then we can check. Really, the difference between the two sides. I don't know if it's possible.
Yes, of course. Of course.
No, I mean for the cameras.
Yes.
If you don't mind, you can check a little bit. So the thing is, if you can close to the patient, closer.
So, okay. You can see it.
Okay, you can see the slight projection on her upper lip, a slight profile, and then the augmentation on the lower lip. So the augmentation was done behind, and the profile was done over the wide roll. Okay. Ça va?
Doctor?
Yes.
There's a doctor from Italy. He
Yes.
wants to know what is the size of the cannula.
25.
25. Thank you.
You're welcome. So again, I'm going to do the same thing from the other side. Ouvre la bouche un petit peu. And non, tu enlèves l'aiguille, s'il te plaît. Non, l'aiguille, petit à petit, c'est ça. Tu m'as donné fine lines. Okay. So now again, on the tension, you see slowly. You see the cannula is here, okay? And then I'm going to inject over the wide roll. That's it. Not too much, but under tension, a little bit. And then I stop. I don't want to see the product coming out in that case. Then you mold all the time. When you mold it, you have to mold it with wet gauze. If you do with a dry gauze, you can make a peeling, all right? So with a wet gauze. And you scratch, you scratch the lip. Perfect. Now with l'autre aiguille. Now with lips, from the same entrance, if I can see it. Okay, then slowly. You see it's very clear. I'm of the submucosal space. And don't push. Do like this, That's it. You see where is my cannula here? I don't know if you look it. So it's not the right place. I have to go back and then now I'm on the right place. You see the right place? Now I'm on the red roll. So now I'm going to inject a little bit. And then I want to see the product coming out.
Excuse me, doctor.
Yes.
A doctor from Poland asked, can you precise the quantity that you use for upper lip and for under lip, please?
The quantity is always related. This is a typical question, about how much you inject. If I have to be honest, my measurements are not really in centimeters, square, very precise, but in syringes. So what I used to do is maybe one at least 2 syringes, if I want to do, the 2 lips. It's very difficult, to precise, 2.5 cent, it's very difficult.
Yes.
Okay, open.
Thank you, doctor.
So if you look carefully, because she has been injected already, I think she has a little bit open, a little bit. She has a little bit too much here, so I'm going to inject a little bit more on the lower lips. But you see, one of the things that when you do the no touch, there's no swelling. I'm not in a hurry, to finish my case because I don't have what I call the B effect. When you touch the lip and then you have blood or you have swelling. I can go, and the patient sometimes, when I talk to the patient, and then sometimes the patient says, let me see at the mirror, and then the patient, what she does, I want more, I want less. So here I want to inject a little bit more. And then again, out. Okay. And then you mold it immediately. Perfect. Open.
Doctor? A doctor from Mexico.
Oh, Mexico.
Yes, wants to know how do you determine the entrance of the cannula? The point of entrance of the cannula.
The point of why I inject from here?
Yes.
It's very simple, because when you from this region I can reach profile, I can reach projection, and I can reach augmentation. And a very important thing is when you are inside, look to that. If you look carefully, I want to go from the projection side to the augmentation side. It doesn't allow me because the red roll is not just a mark, a natural mark. It's an invagination of the muscle. So there is like a small fence there. Mm-hmm. It's the invagination of the muscle that goes into the mucosa. So that's why when you want to do augmentation, is not you cannot do that because it won't allow you to go down. Of course, if you are rude, you can. But the fact is that you have to go down, outside, and then inside. I don't know if you noticed. Give me.
Thank you very much, doctor.
Give me a needle. I want to point it out that le needle, l'aiguille de ça. If you notice, I have done one part and another, but I did not touch the philtrum, because I have to do it with a needle. But I'm not going to touch this. I'm just going to the wire roll. L'aiguille de ça. Ouvre une autre. Ça va? C'est bon. You see, it's very important, ouvrez la bouche. Voyez, you see, everything has been done inside. Nothing has been done outside, and nothing has been done on the wire roll. And at the end, when you see your patients, you have, what we call the gingival line, and then you have the incisor line that when the patient smiles, the lower lip need to match, the incisors. So this is the perfect smile. When the lower lip, matches, the incisors at the upper lip. So now, what I do is I'm going to use, because I did not touch this part, I know. You see? Je sais, ça on a... C'est la dernière. That's it. Okay? You see, whatever you do, from behind is not painful. Even we have done just a small amount of anesthesia at the commissures, and it's not painful. But when you go outside, of course, it's painful. So that's why, I like to do it everything from inside. Another important thing is when you look to the patient and you see, and the patient needs a little bit of support, ouvrez la bouche un petit peu, not too much. What you can do is from outside, you see, you give some projection, but you never touch your lips. Ouvrez un petit peu. I think she needs more here. That's it. And doing so, you never touch your lips. You do all your treatment from outside, and this prevents, a lot of outcomes. Is there any question? It's finished. Ça va?
Already.
Non, ça va? Vous avez souffert beaucoup?
I'm doing fine.
How do you feel?
I'm doing fine.
She can't talk too much, I guess, because she has some local anesthesia, even if she was not too much. But the important thing is that the big difference between this technique and the others is, the first of all, you don't touch the lip. You go through. So you're going to have less infections, less touch-ups, and less edema. 3, we divide the upper lip in 3. Two lateral parts and 1 central part, and the lower lip in 2. 3, we have 3 types of treatment. We have profile, we have projection, and we have augmentation. And depending on the patient needs, we have to choose 1, 2, 3, or all together.
Doctor, a question from Iraq. When you finish the injection and you begin to mass,
Yes.
and you mass from the outside to the inside or from the inside to the outside?
Okay, there's some product still. I want to show you this. No, j'ai fini, hein? I mean, let me just tell you where I am. Ouvrez la bouche un petit peu. So if I am the best, doctor in the world, even the best, I mean, when you inject and you see the product, always there's some product more in this region, more in the other. So it's impossible, believe me, to be exactly, that the injection is exactly at the same size all along, the injection. It's almost impossible. So what I do when I have finished, this is a matter of, it's not a massage, I mold it. And then I mold it, okay?
Okay.
So if you look carefully, this will be in that, okay, if I do this, this is going to be for profile. If I do this, this is going to be for projection. And then what I have done to the patient is inside, this is going to be augmentation. So we have 3, 1, 2, 3. Let me do it from upside. This is going to be profile. This is going to be projection. And this is going to be augmentation. So 3 different, locations.
Thank you, doctor. It's very clear.
You see, there's no, of course. And then my suggestion is always the following. When you do your treatment, you have to ask your patients if he has any history, of, edemas or any problem or vascular problem, because whatever you do on the lips, believe me, is going to have some type of reaction. So depending on the filler you use, you're going to have more or less. But my own experience is the following. Using Filorga lips, I have sometimes more edema, but I have a long-lasting, result. So the only thing you have to teach your patients is to give, some, maybe anti-inflammatory. I use always Fusidine H. Is fusidic, plus hydrocortisone. And if you use this, you have less inflammation and you have less problems.
So this is very good product, the Filmed of Filorga.
That's it.
Okay. And another question, doctor.
Mm-hmm.
For anesthetic, you use the local anesthetic or why you always?
I always use some at the port of entries. Always some local anesthesia. You see, our patient is a very, nice patient, but yes, she suffers, from pain, and this is, is common. So just a small amount of local anesthesia at the entry point. And if you go slowly, and the patient feels the cannula, but as soon as you deposit some, some product, what happened? That the product has lidocaine, so you have numbness.
Okay.
So the thing is, it's not necessary to block the patient, the infraorbitary nerve or the mental. If the patient is very sensitive, sensible, whatever you want to call, then what I do is I place just a small amount at the root, at the vestibular aspect of the just 0.1 or 0.2 lidocaine plus epinephrine, and even at the not at the mental nerve, because the mental nerve enter at the we cannot see here, but the nerves. Give me this just to show you. The nerves enter, at the vestibular aspect in this region. So if you inject just in this region, just 2 drops above and 2 drops below, you don't have to go to the infraorbitary nerve. Absolutely not. All right. So you have to ask your patient if he has experience or not about pain. If she can't resist, I mean, you use maybe a slight amount of anesthesia. But I never use EMBLA. I never use EMBLA because I'm going to be deep. So it's nonsense for me to use EMBLA if I'm going to be below the mucosa.
Okay. Thank you, doctor. And could you tell us, until now, you've finished the injection and how much quantity you used?
I have used just one milliliter of fine lines.
Yes, fine lines from Filmade of Filorga.
And one of lips, Filmed lips. Now it's Filmed, Filorga, but it's the same brand. Okay. For me is Filorga. So here to give volume, I use the lips. That is the one that is, believe me, I have had at least now some experience with the lips. And as I said, it's a very good product. Excellent product. Long-lasting result. But has some type of edema. It doesn't matter. You explain this to your patient, and the patient knows it in advance. She can't go to a party of the lips unless she go to carnival, But the thing is that she's going to have a very good product, for a long-lasting result. And the patients looks for that. They look, for long-lasting results.
Yes. Thank you, doctor.
You're welcome. You have any questions to ask me?
No. Everything is fine.
So you already all finished, and can we show the final result to?
To the patient or to the camera?
To the camera.
To the camera. No.
To the patient too.
Okay, wait, camera, which one? This one? That one. Yes. Okay. So that's it. I mean, all the anatomy. I mean, you can find all the anatomy, in our app. We have an application. It's on the. I don't know if they have launched it on the network, but we have an application. It's oculoplasty.com. That you have all the anatomy regarding the face, the lips, and everything. In case the audience want to have this application, maybe they can contact you.
Okay.
Okay. That's it.
Yes. So, how do you think the result?
I don't see anything. Thank you. Great.
Even if you suffer a little bit, at the end.
Just a little bit at the beginning. Yeah. Sounds great.
Sounds great. Yeah, it looks great.
It's really beautiful.
Nice. Thank you, doctor.
You're welcome.
Thank you, doctor. Thank you very much.
You're welcome.
So stay with us. We'll meet you in a few minutes to our second part of our show. Thank you. Welcome back to our second part, the debate part. And here we have a question, doctor.
Okay.
From the UK. Do you think cannula for all lip augmentation, or is it much safer?
I'm sorry?
Do you think cannula for all lip augmentation, and do you think it is safer?
Absolutely. I mean, I think it's not only for lips. I mean, anything you do on the face. I mean, if you use cannulas, I mean, it's going to be safer. Needle, you know, when you inject, when you use needle, you don't know where you are. And needle makes is sharp. The needle is completely different. So the thing is, when you use cannulas on the lips, you're going to be on a specific space. When you use needle, if you have the best in the world, you cannot tell me if you are at the mucosa or you are on the muscle. Absolutely not. But when you treat, when you use the cannula, and then you feel that you glide, between the skin and the mucosa and the muscle is the right plane. So if the answer is yes.
Thank you, doctor.
Safer.
Thank you. And another question also from the UK is that, is your cannula tip pointing towards the teeth? And on the upper projection, is the cannula tip facing away from the vermilion border so that the filler isn't above the vermilion border? Thank you.
I mean, just to make a resume, on that. If the question is a small question. I tell you why. Because it's very important. You have to follow, the direction of your mark. That's why, we are now on proceeds, to make new cannulas. Because the thing is, you have to follow, where is your mark, and then you direct, your infiltration. So that's why when I want to be, over the wide roll, my cannula need to look up. If I'm on the projection side between the white roll and the red roll, my cannula need to project in that way. If I want to obtain, augmentation, I have to be beyond the red roll, so my cannula need to point down. So the direction of the cannula is very important. And those who don't use cannulas and use needles is much more important, because a lot of cannulas has some type of mark, but not needles. So what you need to do if you use needle, you have to mark, from where the product comes from, just to direct. Why? Because if for any reason you inject with your needle, at the wide roll, and the product goes up, it's going to be a disaster. So that's why you need to direct, very carefully, your cannula or your needle.
Thank you very much, doctor. And how to be maybe immediate or later complication following the injection? The complications?
Using what? Cannulas or needles?
Of your techniques. Your techniques.
When you use, the cannula, you have less complications, believe me, because there's one important point when you use needles. That's what I called before the B effect. Because when you touch, a lip, what happened? You have swelling, you have blood. So that's the first thing. When you use a cannula, you don't have this such edema. You have the later edema due to what? Because the hyaluronic acid captures water. But the cannula, will give you, of course, you have to be gentle. You don't have to be, a Lancelot, of the cannulas. You have to be gentle. Even with the cannula, if you are not gentle, you can injure it. But if you do like I show you, very gently, and smooth, and trying to find the right place, you are not going to have problems. Even embolism is very difficult, with the cannula to go into the artery. It's so difficult.
Okay, and maybe complications for the needles? Can you explain a little bit?
Needles complications is you don't know where you are. Absolutely not. You inject, you have some volume, but this volume is, what is edema, is blood. Sometimes I know that sometimes patients, they don't have this type of, blood effect, but 80%, if you just you think about, what the needle, if you use the needle, what happened, using the needle, you have this edema. So this is the first thing. And the second thing is, you can touch an artery. It's true that when I started with this technique, was maybe 8 or 9 years ago, I used needles, but from outside, never from inside. The technique no touch has been always without touching the lip. I have been doing this always, from outside. And as we know, the artery is behind. Yes. So in 95% of the cases, anatomy is wide different in every single patient. But as you know, from the anatomy point of view, we know that the lower artery is behind and even the upper artery. So the thing is, you can use the needle from outside, but don't touch. My suggestion is do not touch the mucosa.
Thank you, doctor. And for your experience, what is another techniques you may use to optimize the results?
For the lips?
Yes.
I mean, because the lips, when you touch the lips is on the peribuccal region. Mm-hmm. So sometimes you need to give support to the lip, not just infiltrating the lip, but giving support to the labiomentalis fold. Yes. Because the labiomentalis fold to the dao, the pressory angulioris, makes that the corner of the mouth goes down. So if you give support to the lip, not just touching the lip, but touching, the surrounding of the lip, will create, a very natural result. So that's why analysis is crucial. It's not just to go straight down to the lip, and then to do augmentation. You have to do the analysis to see if you have a big dao, if you have a depressor, if you have maybe the patient needs some sort of small augmentation to the mandible, under the chin, because when you have support to the mandible and the chin, this enhances, all the upper lip.
Yes. Can you maybe show it on our patient here? In her situation, which is maybe the best result.
But she's perfect now. I mean, no, the thing is, you talk about what we can do on her. I mean, the thing is, if you look carefully, the dao. No, comme ça. The dao is here. This is where we have the depressory angulioris. And so sometimes, due to the mandible ligaments, and also we have a problem of retrusion of the chin. So we have this is you have this type, of depressor. So what I always suggest in that case with the cannula, what I do is I go with my cannula below the dao, I lift the dao, and then what I do is I inject like if I do, if I do silicone implant, anatomical silicone implant. So what I'm doing is I do less and more, but always, and then what I do, I lift this. This is the first. This is on a deep aspect. And then on a more superficial, just regarding more the superficial fat pads of the lower lip here, then I give support in all this region. And this, makes me, gives me support to the lower lip. And that's the thing, I used to do. Of course, if the patient has the typical, small wrinkles, at the upper lip, I suggest to do, is an excellent, product with Filorga, with an anti-SCF, just making with the roller, and that makes, all these things used to diminish, not say disappear. To make this disappear is tough. Okay.
Okay. Thank you very much,
You're
doctor.
welcome.
So here we have another question. I'm sorry. Just arrived. So here it's from a nurse from Brazil. Can the marinate line?
Muito obrigado.
Can the marionette line be treated from this cannula location whilst treating the lips? Please. Can the marionette line be treated from this cannula location whilst treating the lips?
You mean when they talk about marionette lines, they used to talk about the labio mentalis fold, no? the labio mentalis fold, and I don't like, you know what I don't like. One of my concepts is not to fill holes. This is one of my concepts. I mean, if I have you know, this depression, this a fold, I don't like to fill it because I have to analyze why these appear. And that's why I'm saying, I mean, these appear because we have a ligament here that stops, you know, the aging process. We have the fat diminished on the face, and what happens is this, and this drops down. So my philosophy is to lift, you know, all the marionette lines, you know, giving support, and then. In that case, I'm not going to use volume as a big support, you know, close to the bone. I'm going to use universal. And universal is going to make this, is going to lift, you know, the sulcus. But without this is very important, without filling the hole. It's like when you have a depressor in this region. This is, and the patient said, no, sorry, for the nasolabial fold. No? And they said, I'm going to fill it. This is the worst solution because you are filling a hole. You have to analyze why these nasolabial fold appear and used to why, because the deep mid-fat pad has disappeared and you need to give support to the face, not to fill that is a natural crease. And if you look to internet, you see thousands of cases going down up with the needles or you know, or with a cannula, filling, you know, the fold, and you have to analyze always why this fold, you know, appears. Analysis is crucial.
Thank you very much, doctor. So,
yes. May I show you? Those who are familiar with anatomy, as I said before, you know, you can go to our app. And then if you go to the app, it's you're going to see that you can, is an amazing app where you can go to anatomy, you know, as you can see here. I don't know if you go closer. And the most important thing of this is that whatever you touch is going to tell you what it is. So it's about anatomy. Anatomy is crucial. So that's why we always emphasize that anatomy first, the filler second, always. Okay.
Thank you, doctor.
Any more questions?
Yes.
Please.
And a question from Tunisia. What is the best technique for lips bonder?
For?
For lips bonder.
For lips bonder. What does it mean, bonder?
And for lips.
For lips. The best technique for lips.
Yes.
I mean, I don't know which is the best technique. I use my technique, but not because my technique is. I mean, as I told you, you know, at the beginning, you know, my technique. This I have on my eye, so I have to put it here. I don't know if they listen to me. It's okay, perfect, because I have on my left eye, I wasn't able to see. Anyway, all these techniques come from, you know. It's okay? You listen to me? I'm going to do it like this. I mean, all this technique is not like Javier, you know, in the one morning, you know, woke up and say, I'm going to do this, blah, blah, blah. No, this comes from the clip lip reconstruction, you know, surgery. When you reconstruct a lip for a surgery or trauma or cleft lip, you have to find, you know, the wide roll to give, you know, the profile. You have to give, you know, you have to then bust the muscles to give projection, and then behind to give augmentation, volume. So these three concepts can be applied, why not, to the aesthetics. So analysis of the patient needs, projection, profile, or augmentation is what we decide to publish this article, you know, because I don't know if you're aware with me, but all these techniques, are, when we talk about aesthetic medicine, it's like, something illusion. And we want to convert aesthetic medicine in science. And this, normally, I remember when we talk about, the profile, it was called the Paris lip technique. What is about this? We cannot talk technique about Paris, Belgium, Barcelona or Palma de Mallorca. The thing is that the profile is the junction between the skin and the vermilion. And this is what gives profile to the lip. It's like the gray line at the lid. So if you don't put together these two lines, you're going to have you won't have a profile. So this is anatomy. So that's why always anatomy first and the filler second. This is our philosophy.
Thank you, doctor. And another question for Cupidon arc. What technique, the best technique you use for this part?
Okay, this is a good question. I'm going to show you what I do. Je vais pas vous injecter. What I do is, if you look to the needle, I bend the needle. You see, I have bent the needle. The needle is bent. And then what I do, when I want to do on the patient, I want to do the columns, because the Cupido, all this is the premaxilla here. So I don't go through the lip. I turn my nose, and then I go down like this, and then I inject. So I never touch my lip again. So the typical technique is from the lip to inject, but then you touch already the lip. So what I suggest and propose is to turn, to go down, and then to do your augmentation. Then you do this, 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 and this. So don't touch the lip. Sorry. Is it clear? So you bend the needle 45 degrees, and then when you bend the needle 45 degrees and you turn your nose a little bit, you are able to go down to the columns and then to raise without touching the lip.
Thank you very much, doctor. And another question, maybe, do you use the same protocol for men? Is the same technique?
This is, the technique that, I think the technique is the same, because why? Because men's and women's are the same regarding the lips. They don't have different lips. The lips from a man or the women is the same. You have the profile, you have projection, and you have augmentation, I think. What is true is you can make a lip more feminine and a lip more masculine, Yes. This is another thing, but the lips are anatomically the same, all right?
Thank you very much. Thank you, doctor, for being with us tonight. And we will see you Wednesday, the 13th of March, for our next show. Thank you very much. I wish you a very good evening.
Thank
and
you.
to all of you, thank you. Goodbye.